Dr. K.K. Goyal, Dr. J.T. Brahmbhatt, Dr. Varun Sibal as a chairperson, and Dr. Bhavesh Patel, Dr. Smitesh Das, and Dr. Pragnesh Vora as a moderator. I would like to request Dr. Bhavesh Patel to kindly introduce the subject. This is related to young acute ST elevation myocardial infarction, LYTICS versus PPCI. So I would like to request Dr. Bhavesh Patel.
Anybody, chairpersons, please introduce the speakers. Next slide, please. Chairperson or moderators, please introduce the speakers.
Smitesh, you can also introduce, please.
Good evening, everyone. Today for our first session is Dr. Aman Chaturvedi. He is practicing as he has passed out for DNB cardiology from Apollo Mains Hospital, Chennai, and now working as an interventional cardiologist at Sal and Sanjeevani Hospital. Welcome to you, sir. Our second speaker is Dr. Mukesh Ladha. He has passed his DM cardiology and is practicing as a consultant interventional cardiologist at Sal Hospital, Ahmedabad. He's having an experience of more than 8 years, has performed more than 10,000 cardiac interventions, is proficient in primary angioplasty, complex coronary interventions, peripheral interventions, and cardiac devices like pacemaker, AICD, CRT implantation. He has been an investigator in multiple clinical trials. He's a teacher and has diploma in clinical cardiology at Sal Hospital, has national and international publications to his credit, has presented various papers and interventional cases at national and international conferences, has been invited as a faculty in national conferences, is certified as AFESC and International Associate of SCI. Our third speaker is Dr. Sandar Patel, who has passed from his DM cardiology from UN Mehta Institute of Cardiology, is a director of Aradhya Heart Care OPD Clinic, is performing interventions at multiple hospitals like HCG MediSearch Hospital, Jeevraj Mehta Hospital, AIIMS Hospital. He is well-versed in complex coronary interventions, structural cardiac interventions, peripheral interventions, has publications to his name in Indian Heart Journal, Heartline Journal, and Sudan Heart Journal. Welcome to you, sir.
Sir, all speakers are requested that they remain in time because we have discussion also for 10 minutes. So please be in time. Thank you. Go ahead, sir. Speaker number 1.
My slides are visible, sir?
Yes, it is visible.
Yeah. So good afternoon all to CardioCon 2022. Yeah, the first topic is the primary PCI versus thrombolysis in the acute MI setting. And my topic is to speak on the primary PCI in anterior wall MI. This gentleman, 23-year-old male patient, fully vaccinated for COVID-19, presented with acute anterior wall MI within a 2.5 hours, and it in class 2 Killip with an almost normal hemodynamics and ongoing rest pain. So after giving a loading dose and the statin, what should be the ideal therapy, fibrinolysis versus the primary PCI? That we have to decide. And before selecting a reperfusion therapy, we know that this patient is within a window period, and that we have to see the extensive anterior wall MI. That means patient myocardium, a big myocardium is involved, and massive MI, and the risk of bleeding if patients go for lytic therapy, and the total ischemic time from the symptom onset to the reperfusion means the opening of the artery, and the time required for the transportation to the Cath-lab, and our patient is already reached to the Cath-lab enabled center. So the proper, the ideal treatment for this patient, we have to select from the thrombolysis and the primary angioplasty. But there is no doubt in my mind that this patient is the ideal candidate for selecting for the primary PCI, because according to the guideline, if patient diagnosed with the STEMI, if you can open the artery within a 120-minute, then that is the ideal therapy, that primary PCI. And I am sure that my friend Dr. Aman and Dr. Sandap, they also can do primary PCI within a 30-minute time period. So this is the ideal way, this is the ideal treatment. This patient, if go for primary PCI. The reason number 2 is that if these patients go for fibrinolysis, then the chances of opening the artery, the chances of the TME3 flow, that is only 50%. In contrast, the TME3 flow can be achieved up to 96% in the primary PCI, and that is the biggest advantage, and that decides the prognosis of this patient. That's why I'm suggesting the primary PCI in these patients. if you go with the data, you see within the first 2 to 4 hours, even with the best molecule which available as a fibrinolytic therapy, you will achieve TIMI3 flow in 62% of the patients. And that's why the primary PCI is better. If you see after doing the primary angioplasty, you are sure that the artery is open, is flowing very well, and you are 100% sure that this patient is going to be benefited. In fibrinolysis, you have to rely on the certain clinical criteria and data. So I would suggest, and again, the reason 3 number is the reinfarction. The reinfarction means the reocclusion rate of the artery may be as high as 10% in the hospital and up to 30% by the 3 months. And as the time passes, after 6 months, death and the reinfarction is almost 10% in the fibrinolysis group compared to the 4% in the primary PCI group. So the reason number 4, I would say the stroke. The hemorrhage is another a big factor. Intracranial bleed, even though it is a 1%, but if young guy, if develop bleed, that is the biggest catastrophe if it is young in his own family. So I would suggest that this is the again number 4 reason. If you compare the almost negligible risk of stroke in primary PCI compared to the 3.3% in the lysis group. And if you are selecting for fibrinolysis, you have to exclude almost absolute as well as relative contraindication. And if suppose this patient belong to that category, then there is no choice rather than sending patient for the primary PCI. And reason number 6, thrombolytic therapy is more time sensitive, because as the time passes, the thrombolytic therapy is less effective. And in this in one of the major paper that has been established that if you thrombolyze the patient within a 30 minutes, that effectiveness is more. And as the time passes and after 2 hours, the effect of the efficacy of the thrombolysis is reduced. And in that scenario, the primary PCI has great role. Now, what are the clinical evidence suggests? The data itself says that the Prague study, the largest study and first study which has been done between the primary PCI and the thrombolysis, almost all the patients were enrolled in 3 different groups. The group A, the thrombolysis group, the group B, the thrombolysis, and followed by the angiography and plasty, and group C, the PCI directly. And if you see almost 1500 patients enroll and compare, and that shows that group A, the mortality is 14% compared to group C. That means the in primary PCI 7%. So means anyway, if patients go for fibrinolysis, you are almost 50% of the mortality you can save by doing a primary PCI compared to fibrinolysis, and that is the biggest advantage. See that 23% of the mortality in thrombolysis group compared to 8%. So that means the biggest advantage you can give, that is the death benefit, that is the mortality benefit in primary PCI group. Even though patient is thrombolized, the 7% of the patient, they go for the rescue PCI because of the chest resting pain or any other reasons. So these are the favoring data in terms of primary PCI. Now coming to the Prague 2, this is the larger study, almost a similar kind of study comparing thrombolysis versus the PCI. And again subgroup analysis was done between 3 hours and 3 to 12 hours, and that shows that after 3 to 12 hours there is significant difference in the mortality, almost 6 to 15%. That death benefit is almost more than double. The reason number 8, again a landmark trial, that is DAPT trial, that it is a Danish population study that again compared between the thrombolysis versus the PCI, and that has shown that there is 75% reduction in the reinfarction, and 30-day mortality is 24% in the fibrinolysis compared to 6% in the primary PCI, almost 4 times mortality reduction in primary PCI. Now, this is the largest follow-up data, the DAPT 2 trial, the 16 years follow-up of primary angioplasty versus fibrinolysis, and that shows that even patients who went for primary PCI, they do really remarkably well in terms of all-cause death, rehospitalizations, cardiac death, even after primary PCI. So the benefit of the PCI immediate as well as long-lasting, and that should be the ideal therapy in this patient. Now, this is the interesting study, that CAPTIM study that has been compared between the pre-hospital fibrinolysis versus the PCI. In our health setup, the pre-hospital fibrinolysis is not possible, but this is the FAIR study that has shown that some benefit is there in mortality in terms of thrombolysis, but that is the pre-hospital thrombolysis. Anyway, the composite endpoint favoring the primary PCI compared to thrombolysis. Even though the mortality rate is less, but the least mortality was in the primary angioplasty group. And again, this is a major benefit. Now, if you compare all the major clinical trials like Prague, CAPTIM, DANIM 1, 2, and Prague 1, 2, that there is that all the trial favors the reinfarction, favor the primary PCI, stroke also favor the primary PCI, death, which is the major advantage in terms of any kind of benefit you want to give, that favors the primary PCI. So that meta-analysis conclude that even when transfer to an angioplasty center is necessary, the primary PCI remains superior to the immediate thrombolysis. And this is again a different case scenario where ST elevation, the patient presented to the non-capable center, and then compare between the fibrinolysis versus the patient sending for the primary PCI. Even you are sending patient for primary PCI, then also you can reduce mortality by 5.1% compared to 7.7% if you do fibrinolysis. Now, the last thing, that the new concept, that culprit versus the complete revascularization, and that you can do only by angioplasty, and that in all the major trials, these are the small number of study, but really gives a great benefit and great reduction in all cause of composite death and MI. And that shows that the complete revascularization could be beneficial once it allow for the fast reestablishment of the blood flow, increase the viable myocardial area, and leading to an improvement of the left ventricular ejection fraction, and the reducing vascular complications through the lesser need of punctures, reduce hospitalization time, and prompting an increase in cost effectiveness. So I would like to conclude that the primary PCI is superseded by many reasons, like higher rate of patency, greater number of TIMI3 flow, lower rate of recurrent ischemia, reinfarction, emergency repeat revascularizations, and almost negligible intracranial hemorrhage, and the massive mortality benefit and less hospital stay, and is more effective rather than if you lot of contraindications and complications with fibrinolysis and the least effective therapy. Thank you so much.
Thank you, Mukesh. Very well in time. Now I would like to request Dr. Aman Chaturvedi, if you are ready, sir.
So I am very thankful to the organizing committee that they asked me to present a topic today. And I am very grateful to Dr. Mukesh that he presented such a nice talk today. He is very nice speaker. So I'll be arguing on the Indian scenario of the current situation. If we think about the Indian scenario, then why will we prefer a pharmacoinvasive strategy over a patient in such a case? So what do the guidelines suggest? The guidelines suggest that if the patient is reaching the hospital in the time frame of 120 minutes, or the door to the balloon time is less than 120 minutes, then only you can think about doing a primary PCI. Otherwise, if it is possible, you should think about doing a fibrinolysis followed by a primary PCI. This is the 2017 guideline, what it is saying. And what is the time to muscle? The more time you waste in doing any intervention or any revascularization strategy, the more muscle you are wasting. Even if you thrombolize a patient in the ambulance, or if you do pre-hospital thrombolysis, or if you do a thrombolysis just in the ER, that will be saving the muscle. So that will be more beneficial for the patient. So this is my second point. So if you see this graph, it is showing that how much time is going on and how much muscle and how much mortality is increasing. So as the time, so if you see this slide, you can see that as the time increases, there will be increase in mortality and there will be increase in death if you don't revascularize the patient. And the other thing is that door to needle time. Door to needle time is hardly marginable, or it is means it hardly takes almost 20 seconds with the newer anti-thrombotic agents. It will take 30 minutes to, and that will increase. See the hospital mortality percentage. Thrombolysis in less than 30 minutes, it will be almost 7% mortality in the hospital. Then the other thing counts is that the total ischemia time. So in our case, the patient has presented almost like 2.5 hours after the chest pain started, and his first medical contact, and the admission time, documentation time, and everything, if you account, then it will take around 4 hours, 4 to 5 hours for completing everything. If you don't go into documentation, then also it is going to take around 3 hours. So then also, if you do thrombolysis just before doing a primary intervention, then it is going to be beneficial. Now, if the patient has a cardiologist, or there is any complicated procedure going on already in the Cath-lab, or there is a TARI going on, or there is a primary PCI already waiting in the ICU, then what other options do we have? We don't have any other option. We have to go for primary thrombolysis, then we have to think about going for a angio and rescue PCI. Then the fifth point will be efficacy and patency of thrombolysis. So many trials have shown that the newer antiplatelet thrombolytic agents like tenecteplase, reticlase, and tissue plasminogen activator have almost the efficacy of 85% to 70%. So, and they will give almost like TIMI 2 to TIMI 3 flow. And following that, we can go for angiography and angioplasty. So then also our time will be saved in that, because giving an injection will almost take like 10 seconds for giving a bolus of tenecteplase or reticlase, and continuous infusion or a second bolus of tenecteplase or reticlase. In our patient, the TIMI score is like 6. So his mortality is around 16% in 30 days. So it will be very hazardous to keep a patient waiting just for the documentation or other parts of the thing. Another issue is that there are no reflow or no flow phenomena happening without thrombolysis. Even if you do a primary PCI, take the patient for stenting and take the patient for plasty or anything like that, even after crossing the balloon or even after crossing everything, there is no flow in the LED. So what you can see in this picture is there is no flow in the LED. If you thrombolize this patient, there will be increased flow, there will be reduced thrombus burden, and you have more chances that a nice an example of a patient in whom primary PCI was done and there was no reflow, and high ischemic burden was there and there was no reflow, and almost like there is scarred anterior myocardium, and you can very well judge that there will be a poor prognosis in the coming months. Then the other thing is that pathophysiology of STEMI. In our current scenario, what we have been given, it is a 23-year-old young male. The most common etiology will be a plaque rupture. And the plaque rupture will be mostly a red thrombus. It won't be a white thrombus, it won't be a stagnant thrombus, it will be a red thrombus, and it will respond very well to thrombolysis. And many of the cases which I have seen till now, they will have a resolution of the thrombus burden and a resolution of even the stenosis even after thrombolysis. Even if you do thrombolysis and do a CAT after that, the patient will be very well and there won't be any plaque or any stenosis, any residual stenosis left. The sixth point will be cardiac necrosis in STEMI. The more time you waste, it is a basic concept. The more time you waste, the more muscle you lose. So if you lose the muscle, there is no sense of doing any intervention procedure access. So the basic thing is that as soon as the patient is coming, you don't have time, just thrombolize him. Take him to the Cath-lab, take him to the interventional area and do whatever you want to do with him. But thrombolize him. Clinical trials, like Mukesh sir was pointing out many clinical trials, what he had said. There are many clinical trials which are supporting pharmacoinvasive approach also. So this was the first trial. The fast MI trial that also showed the same thing, that even if you do thrombolysis, even if you do thrombolysis followed by PCI, they are going to have almost like the same outcome. Then the Gracias 2 trial came. It is also showing like the primary endpoint of the study was composite of death and which showed significant combination, that major bleeding and no significant difference between the two groups. Then transfer AMI study came. Then Minneapolis study came. Then STEAM study came. Then STEAM conclusions came. STEAM update came. What the update says that as the time increases, like if you see this graph, you can very well recognize that as the time increases to the doing a reperfusion strategy, either be it thrombolysis or either be it primary PCI, as the time increases, you are going to have a decrease in LV function, and primary PCI won't be better if you don't do time strategy. As soon as the time increases more than 50 minutes to 60 minutes, it is not going to be better. So better it is going to be that you do a pharmacoinvasive study. Sinus trial came. Then some few other points is easy to administer. Major adverse complications are not that much. We say that there are too many major adverse complications, but it is less than 1% with the newer agent. Then relatives and social issues. You take time to explain to the relatives the cost issue, the explanation to the family members, the explanation of mortality and morbidity. It takes time. And it decreases chances of multiple stents once you do a CAG. And even if you want to send a patient for a bypass, you don't have to, like, the culprit vessel will re-thrombolyze.
Thank you so much. He has done very well within time. I would like to request Dr. Sandarbh Patel for the next lecture. Dr. Sandarbh Patel.
Yes, sir. Good evening. Thank you very much, Dr. Jayesh, sir, and the organizing committee for allowing me in the initial session of this wonderful conference. Sincere regards to Dr. Kamal Sharma, sir. Excellent talk by Mukesh Bhai and Aman Bhai. And also I saw a little bit of hint of Dr. Kamal sir's style in Mukesh sir's presentation, which is of course saying this is an honor for Mukesh Bhai, as we have seen Kamal sir many a times. Coming to the topic, my point today would be TPA is preferred agent for lysis in COVID-19 era. So a lot of my points have been covered by Aman Bhai very nicely, that why we should go for thrombolysis. So my work is made pretty easy. I may have to skip some slides also. The background of the patient we know. With TIMI score of 6, this patient doesn't fall into much high risk category. That is one important point in a STEMI when we consider whether to go for thrombolysis or PCI. So this patient is not in a very high risk category. Thrombolysis can definitely be considered. He is a young male. Most of the time we see that in young male there is high thrombus burden. Sometimes when we do angio in place like UN Meta where it is thrombolized outside, there may be thrombus burden. We give tirofiban, thrombus goes away. That part is important. It's a COVID wave scenario. In Omicron, many people are comfortable with Cath, but in last year, April, May, when I was sometimes willing to do a Cath-lab procedure, but there was no Cath-lab which was taking COVID patients. So that is also important thing. Of course, as I said, there is no cardiogenic shock. The time duration part has been taken care well by Aman Bhai and Mukesh Bhai. As this patient is at 2.5 hours in hospital, perhaps by within completion of 3-hour time span, we may be able to give fibrinolysis. As we know, at every 40 seconds, someone, even young or older, may be dying with cardiovascular disease. Now, COVID-19 is a very highly contagious disease. Proximity dependent spread is there. with aerosol maybe remaining viable for hour to many hours also. So once you take such patient in Cath-lab will be out for few hours. So other non-COVID patient may suffer. Most screen for COVID-19 tests may be negative up to 30%. And 80% of patients of COVID infection are asymptomatic. So even in Omicron era, when this is not severe, but 80%, many asymptomatic patients may be there. So COVID screening is definitely necessary. So all this COVID screening and part will also take its own time, and time is muscle with ST elevation MI. So we should ideally do COVID screening. At the same time, we should not do delay. What can be done? Thrombolysis is ideal. Infection of healthcare workers is a major concern. Italy, Spain, USA, India, a lot of healthcare workers get infected. Even with PPE, personal protective equipment, total safety is not there. Confirmed or suspected case to cardiac cath-lab will expose all the staff and also disable the laboratory, as I said. Necessary delay after hospital arrive occur due to the triage protocols during this COVID-19 era. Important focus of today's debate should be PCI is definitely preferred. I also agree. And being an interventional cardiologist, anyone would agree that PCI would be preferable to thrombolysis when there is a cath lab like, there is a hospital like SAL with this patient where beautiful cath lab is there. But COVID-19 scenario, triage protocols, and also other things in Indian subset, we have to explain the relative in detail, window shopping, opinion, this, that takes 1 to 3 hours. Why waste those 3 hours and why not thrombolyze? Early reperfusion is always important than the mode of reperfusion. Immediate fibrinolytic therapy in emergency department may mitigate the system-based delays, of course. And then we see various recommendations from various institutes across the world in COVID scenario. So patient without thrombolytic contraindication first start intravenous thrombolysis, and then segregation to various department, ICU or ward can be done. Reperfusion of STEMI in COVID era. Experts dealing with COVID-19 epidemic in China or place like USA have been preferring over last 2 years the fibrinolytic therapy. Blanket policy of PPCI in all patients will be hard to justify, and there are operational issues. So scenario or situation in these times favor fibrinolytic strategy. Of course, this part we have seen high risk, low risk, preferably thrombolysis, and if contraindications or if failed thrombolysis, we can go for PCI. In stable patient with confirmed or suspected COVID-19, PCI can be deferred as first-line therapy and fibrinolytic therapy should be given. Patients in one study who were treated with PCI, 21% had stent thrombosis. So this factor should also be considered or kept in mind. Patient is fully vaccinated, but still he could have got COVID. And whenever there is COVID, in compared to routine scenario of 1% stent thrombosis, this 21% stent thrombosis, and stent thrombosis in a young patient would be even more devastating than the actual disease. How can we balance this? So isolating the patient, confirmed or suspected, starting the thrombolytic therapy would be preferable. If acute STEMI is there, as said, consider fibrinolytic therapy if no contraindication. If we see the current recommendation, low risk patient considered for thrombolysis. In high risk patient, if all PP is available, healthcare personnel are well versed, then only primary PCI is preferred. Now, this was about what should be the treatment, primary PCI, thrombolytic therapy, in my view. Then which agent? Fibrin specific agent should be preferred. Fibrinolytic therapy more frequently aborts the myocardial infarction, less personals are required, and up to 75% will achieve the infarct artery reperfusion. Even TIMI 2 flow or 1 flow will help salvage a lot of myocardium. Fibrinolytic therapy and pharmacoinvasive strategy offer a logical, effective, and simple alternative to complex ergotherium of primary PCI. This is, of course, factors favoring the fibrinolytic-based pharmacoinvasive approach. Non-PCI or even PCI-capable setup in COVID scenario. Low risk, no absolute contraindication to fibrinolysis, and less than 3 hours, which is our case. And if we see in hospital mortality rate of patient hospitalized with acute MI, before and during COVID pandemic period, then in COVID pandemic period, the mortality is higher side. In STEMI patient, fibrinolysis is comparable in hospital and 30-day primary composite endpoint in COVID-19 pandemic era. So previous data we have to forget and see what is the scenario in COVID. So their fibrinolysis is also comparable. ACCHA also says that appropriate timely use of some form of reperfusion is important in COVID pandemic rather than the best ideal choice as per guidelines of previous times. So proposed redesigning of STEMI care would be dual goals: timely reperfusion and healthcare personal safety. Hospital without PCI capability go for fibrinolytic or transfer if contraindication. PCI capability is there, then if PPE and all is available, you can consider fibrinolytic for low risk stable patients. Rapid and safe discharge can be there, and monitoring the system performance is also important. So this fibrinolytic agent would be class 1A or class B, fibrin specific agent particularly. If we see about TPA or the alteplase, it has shown superiority in mortality reduction compared to placebo, also compared to streptokinase. Accelerated TPA followed by heparin reduces the mortality and a significant reduction in mortality. As we know, alteplase is more fibrin specific, direct plasminogen binding, no allergic reaction, plasma clearance is quick. Thrombolysis for acute MI, alteplase versus thrombolysis is, as I said, superior. If we see the major trials of comparing 30 to 35-day mortality among fibrinolytics, then we see that alteplase in Gusto 1 is superior. We know that reteplase is not showing any particular superiority to alteplase. So over and all, fibrin specific agent like alteplase when given with accelerated regime would be much interesting. So in nutshell, COVID-19 era, early reperfusion with minimum risk to the patient as well as healthcare worker is the way forward. Safety of healthcare worker is utmost important when already burdened healthcare infrastructure, as we see in Indian scenario. Time-tested fibrin-specific agent like TPA serves the purpose, achieving the coronary reperfusion in high majority of patients with time conservation. Thank you.
Yes, we can go ahead with the discussions. If there are any questions, it is being said that here in this case particularly, patient has been fully vaccinated 3 months back, and now he has developed anti-revolve myocardial infarction. So the antibody level of COVID, spike protein antibody level must be good enough. This is what I understand. So now you can discuss out.
With due respect, sir, I read one article, over more than 1 lakh patient study of AstraZeneca and some other vaccine. They had studied Delta and the previous strain. Then at 9 to 12 weeks, the antibody level after 2 doses of vaccine had gone significantly down, and they had studied the patients who had double vaccinated and hospitalized. So hospitalization course with COVID was as severe as non-vaccinated people. That's why the booster recommendation and all. So I guess 3 months is an important time period where perhaps some antibody level may have waned, and this patient is a potentially COVID infected patient.
And then the other point I'd like to say is that a young patient having a MI, acute level MI, it won't be like a heavy plaque burden or something like that. It will be some plaque rupture or having an acute thrombotic event. I think it will be better in the scenario.
Yeah, Sandar, I know Sandar Bhai and Dr. Aman has put their thought in a right way. And I would like to say that this patient, young patient, massive anterior MI, already reached to your center with the Cath-lab facility, then definitely there is no doubt in, giving a major benefit. And that is the major advantage, that is the death benefit that you can give by angioplasty. Second thing, now initially when COVID started, that time everyone was to do the procedure and all the Cath-lab intervention was quite difficult. But after giving all, as COVID doses, vaccination doses and booster dose, and I know that our even the medical officer are well aware of how to screen the patients and how to go ahead with COVID protocols. And this is just in minutes, not in hours. That can be done in minutes also. So I think that without any doubt, angioplasty is the better option. But I would like to be happy if this patient is far away where the Cath-lab facility is not there. Then definitely the pharmacoinvasive has role. And that time you can choose that therapy, fibrinolysis therapy followed by angioplasty.
Sir, what about thrombolizing the patient initially and just bringing him to the cath-lab?
Then it would be a sorry to intervene. Then it would be a facilitated PCI if you are doing in a cath lab center, and the results for that are not that great. They support pharmacoinvasive where the cath lab is not there; it's quite far away, and definitely we usually see high thrombus burden is there. And after successful lysis, also as sir has also told that reocclusion rates are quite high, and we do need to do an angiography because thereafter we can identify the anatomy, and also we might need intravascular imaging like IVIS studies, OCT, to identify how the plaque is.
Yeah, that is fine. That is fine. If you do thrombolysis within 3 hours, if you do PCI or if you angiography, that is also means it is advisable to do a PCI or an angiography within 3 hours of thrombolysis. That is fine, but if you do immediate thrombolysis, won't it reduce the thrombus burden? Won't it reduce the ischemic muscle? Won't it reduce the myocardial damage? And in a young patient like this, I think it will be advisable to have a initial thrombolysis followed by a PCI.
Yes,
I also agree to Aman bhai very much that nowadays we don't talk about door to balloon time also even. We talk about door to wire time. So the concept is that when the wire is passed, there is some whatever flow comes with passing the wire through the lesion that will also help salvage the myocardium. So I guess the thrombolytic agent like tenecteplase or reteplase or even alteplase that will establish enough flow majority of times to akin to at least passing a wire. So that will salvage a lot of myocardium. And most of the times we do follow COVID protocols. And now the way we almost gone and all is fine. But otherwise, even doing a rapid antigen test spends 20 minutes. So we'll almost go beyond 3 hours of thrombolysis period and all. And in young patients, when secondly also thrombotic burden is high, and if COVID situation there, it will be even higher. But then many times during our procedure, if thrombus is we are not able to tackle the thrombus, we give intracoronary thrombolysis also. So doing all that thing in place of that, why not give IV thrombolytic?
Yeah, that's what I am saying.
So the only thing that I would like to mention or ask rather to Dr. Raman and Dr. Sundar is that the guidelines, if we just stick to our own clinical vignette, the case given to us, the patient is a young male, his saturation is 96%. Nowhere we have been given a situation where he's supposedly infected from COVID. The standard guideline norm should be that if there's a non-PCI center and if you can thrombolize the patient within 10 minutes, that is the gold standard. You can do that. To have a PCI center, there is no reason not to take this patient up for PCI purely for an academic discussion. If we are having a Cath-lab enabled center, and even if we consider it to be a COVID situation, the recent registries of AHA and Euro PCI, they mentioned that if you manage COVID patients and if your healthcare personnel is sufficiently trained enough to manage a COVID patient with STEMI, PCI is the gold standard from the limited registry. There are no guidelines purely for the fact that the world is evolving, learning about the COVID itself. So we'll take a while to come up with a guideline with reference to COVID. But if we just stick to the current situation, best clinical vignette, my personal say would be more for PCI than fibrinolysis. If you recommend fibrinolysis, I would love to know why and exactly not a PCI for this particular patient.
Look, I like to give an explanation that like we don't stick to the guidelines completely. We don't have to stick to the guidelines. Guidelines are made and they are changed every day and the other day. They will change. So what our experience is and what the experience of other cardiologists are saying that if you repurpose the patient, it is going to save the muscle. No, it is a simple concept.
Okay, my simple question to all of you is that it's a COVID thing. So do you think that D-dimer values would matter in taking that call? If this patient was, say, with a D-dimer of, say, 5,000 versus, say, 500, and he's come to you right away, and if you can do a point-of-care D-dimer, would you still consider a TPA as a better strategy, because now we have data for that as compared to any LYTICS, versus PCI, primary PCI, if the time delay is going to be huge? Open to all the chairpersons, moderators, as well as speakers.
Absolutely, sir. As you pointed, if you have evidence of probably having a concomitant hypercoagulable state or a thrombotic burden that is going to be affecting more than just cardiac tissues or coronaries, TPA would be a better strategy given the circumstances. If not, there is no reason not to take this particular patient up for PCI.
PCI would be first choice from my end also. And regarding the time delay, it has been specifically mentioned in all the trials, whether it's stream registry or whether it's in Tamil Nadu registry, where in Tamil Nadu they use STK, but the time window was less than 3 hours. And most of the patients thereafter were did underwent for coronary angiography and angioplasty thereafter. So only lysis will not help. And obviously, if it's a young patient, we have to assess the coronaries. If it's an plaque burden, I have seen, we see usually patients presenting with such scenario, and then, you know, there is evolving thrombosis that comes to LMC. Patients can go into sudden cardiac arrest. Definitely, bolus lytics are the preferred strategy, and definitely tenecteplase and alteplase much more are preferable compared to retiplase. But one thing, even in the periphery, when these agents are transferred, the risk is whether cold chain is maintained or not. Many of the times they come and they don't work. STK is not available in USA, and most of the patients, when we go on the topic of debating about the cost, well, PCI can be done at a cost of less than 1 lakh. When you go with retiplase and all, the costing of hospitalization, everything comes around 60 to 80,000 in between if the patient has to be managed, even without angiography sometimes. So cost, if you are using newer agents, won't be the issue when going for primary PCI.
Even though if you thrombolize the patient and then guessing that this patient may do well, even though there is a risk of arrhythmias and all other things, so rather than guessing, you know, you are giving a definite result in primary PCI, and that is the definite treatment.
And the point is definitely well taken. If it is in a periphery setting where Cath-lab is not available, we have to lyse the patient. In fact, in stream registry, yes, it was documented that when you are transferring the patient, tenecteplase was used. It was a preferred agent. But yes, again, the problem is with the cold chain. And suppose if it was an inferior wall MI with shock, you can't go with STK upfront. If RVMI is there, patient will deteriorate. You have to go only with the bolus lytics agents at those cases.
So all I also wanted to mention was on the similar lines, that rather than going for a facilitated PCI and then eventually converting it to a rescue PCI, it's better to go upfront with PCI in this particular situation.
True.
Yeah, but definitely if it's in periphery, you have to go with lytics. Don't waste time. And then transfer to a PCI capable center. And as Dr. Vijayban sir has clearly told in his inaugural lecture that we are doing only primary PCI in 5% of the cases, that has to change. That scenario has to change. So effectiveness of primary PCI is not yet demonstrated very effectively in India, though cath labs are coming all over.
Getting a D-dimer level also will take time. I think we can't wait for the D-dimer level to come and then decide whether to thrombolize or go for primary PCI. As a interventional cardiologist, all of us, I think, in PCI enable center, primary PCI, and in non-lytic hospital, lysis.
True. And I just want to share.
I think Aman and Sundar be like Bazigar, haar ke aage bhi jeet hai. You are interventional cardiologist. You have to do primary PCI only.
I would just like to ask all the interventional cardiologists, what is the use of thrombosuction devices? Because it has been 3 years, I've done more than 1,000 angioplasties, around 1/3 of the cases are primaries. Till now, I didn't have no reflow when I have done the patient with proper, if you are using GP2B inhibitors and with newer drugs like ticagrelor or prasugrel is there. So cases of no reflow are comparatively less as compared to earlier when you used to see around 2016 or 17. When they were
True, because if you see in last 5 years, hardly almost 4 or 5 times I have used thrombosuctions. Rest of the time the things, you know, solve with just a plain balloon only. So you are right, the use of thrombosuction is drastically reduced. Even with newer drug like cangrelor, that is also a wonderful drug we can use in the primary PCI, and that is also a new age.
I'd like to add a point that the use of thrombosuction has reduced from class 1 indication to class 2, class 3 indication. So you don't have to do thrombosuction. It is like almost like contraindicated to do thrombosuction even in heavy thrombus burden.
So I think our discussion is almost over because we have a speculated time. So during that time, sufficient discussions have been made. When we meet again, we will have further discussions on the same topic. Now I would like to go to BOUT number 2.